So now we should be live. We should be going live and on Zoom. Thank you for your patience, everybody. It's redirecting to Facebook Live. I just want to make sure, since it is 11:03, that we... Okay, very good. Wonderful. Well, Dr. Becky Lynn, I'm thrilled to have you on today. This is Dr. Linda Bluestein, the Hypermobility MD, and I'm here today with Dr. Becky Lynn, board certified gynecologist and director of the Evora Center for Menopause and Sexual Health. Thank you so much for joining me today.
Oh, thank you for having me. This is fantastic. I'm excited to talk.
Wonderful, wonderful. Well, I feel like, there's so many different things that we talk about in terms of pain, but I feel like pain with sex is something that we just don't talk about like we probably should. And in my practice, I know that I feel like so many people feel like they're the only one. And there's nothing that can be done, right? So I was watching some of your interviews in preparation for this, and I noticed a common theme that you're saying there are things you can do. This is what I'm always saying. Tell us how you got interested in this area of, you're super specialized. Tell us how you got interested in that to start with.
Sure. So I finished my residency a while back, and I went and joined private practice. And during my residency, we did not learn anything about sexual function. Nothing like, we learned how to deliver babies. And I agree that's very important if you're going to be an OBGYN. But we didn't really learn about sexual function. And when I went into private practice, I was asked all the time, what do I do about my low libido, or I'm having painful sex, or I can't reach orgasm? And when I started in practice, I didn't have an answer. And I got a card in the mail. This was pre-internet. And it was a conference that was happening in Chicago on female sexual function. And I thought, oh, fantastic, I'm going to go take this course. So I went up there, I took the course, I learned so much. I came back with, a good understanding of female sexual function. And I had, answers. Here's what you can do about it. Here's what we know. But I was a general OBGYN at that point. I wasn't highly specialized. Ultimately, I went to the University of Missouri and Columbia, went back into academics. And the funny thing is, at a faculty meeting, one of our physicians was like, I don't know what to tell women about this. I really prefer to operate. And I said, I'll see those patients because I feel comfortable talking about sex and I know it's an embarrassing issue. And so then all my partners started sending me all of their patients, and I thought, okay, now I really have to learn this a little bit deeper. So I found ISWISH, which is the International Society for the Study of Women's Sexual Health. It's a fantastic organization. It's built up of practitioners, not just OBGYNs, but psychiatrists, internal medicine, women's health experts, pelvic floor physical therapists, and they even have patient advocates also. And I took a course, I did a preceptorship, I've been going to conferences. I became a certified sexual counselor through another course or series of courses, and I've just made it my specialty. And I really enjoy it because, like you said, sex is such a taboo subject, especially when it comes to women. And many women worry, what is wrong with me? Or why am I the only one this is happening to? And they don't know who to go to or talk to about it. And so I love when people ask me about it and I can help them and just reassure them they're normal. This is what happens. So I really enjoy what I do because I know I'm really helping people.
That's fantastic. And it's such a desperately needed area of work. I know that when I've had conversations, my husband's a urologist. I don't know if you knew that.
There you go.
Yeah. And I remember when I first was, discussing with him about the pelvic floor and some of his colleagues and realizing that, there are pelvic floor physical therapists, but other than them, it seemed like most other specialists didn't really know a whole lot about, for example, the pelvic floor. And obviously there's lots of reasons for painful sex, right, besides the pelvic floor. But that's when I really realized, wow, there's so much work that's needed in this area because there's so many things that you need in order to be able to have a healthy
Right.
relationship in that way. And so there's so many things that can impact it. Can you
Yeah.
give us an idea of some of the things that you do in the process of working somebody up? What are the things that you're looking for? What are some of the interventions that you might recommend? That kind of thing.
For painful sex, you mean?
Mm-hmm.
Yeah.
Yeah,
So
like kind of the approach that you take.
sure. So the thing with painful sex is it's usually multifactorial. And I think it's really important when you see a practitioner, that they really have an understanding of pelvic pain, because it's not just, oh, let's get you an ultrasound, your uterus and your ovaries look normal, it must be in your head. That is definitely
Right.
not the right answer. There's so many things that can cause pelvic pain, and many of the things that cause pelvic pain, people have one or two or three of them. So endometriosis is a common gynecologic condition that causes pelvic pain and painful sex. Endometriosis is where you get the tissue, the endometrium, which is the tissue that you shed each month when you have a period. That implants in the abdomen and pelvis, on the ovaries, on the bladder, on the bowel, and just causes excruciating menstrual cramps. And then that causes painful sex in general, because the pain tends to become all month long rather than just during your period. But pain in the pelvis, the response to pain is for women to contract the pelvic floor. And that contraction of the pelvic floor then makes sex even more painful, so they contract even more. So let me just explain what the pelvic floor is for people who don't know. If you think about a human skeleton, and there's like the pelvis, right? Like you can press on your hip bones, there's the pelvis, there's a hole in the bottom. We have a hole there, a baby can fit out. But really what you don't see when you look at a skeleton is that there's a hammock of muscles, kind of like this. I'll do my best to show it. That the vagina goes through, the colon goes through, and your uterus sits on top of the pelvic floor. So basically the vagina is just, a long hollow tube. Like if you're standing, it's this way, and it's surrounded by muscle. And so those muscles, sometimes due to endometriosis, any sort of pain in the pelvis, whether it's hip pain, like a labral tear or whatever, you can develop that pelvic floor muscle hypertonicity or muscle spasm, and then the muscles around the vagina go like that, and then sex hurts. And what we hear patients say usually, or women say about this is, we try and have sex and he just can't get in, or he's hitting a wall. Okay, so I got off on a tangent. So I was at endometriosis. That's one thing that causes painful sex. Other things that cause painful sex are an entity called interstitial cystitis, which is also called bladder pain syndrome. And these are people who feel pain in the pelvis as their bladder fills. And there's not a great way to diagnose it apart from the history. So somebody may see a urologist and they get a cystoscopy, and the cystoscopy is normal, and oh, well, you're fine. But you can definitely have pain with urination, or pain as your bladder fills, which leads to painful sex, where you don't see anything on cystoscopy. So that's another one. Vulvodynia is sort of a similar entity where you just have pain in the vulva, which is the outside of the vagina. And you do an exam, there's no yeast infection, there's no dermatologic lesions of any sort, but the vulva just hurts, and that can definitely cause painful sex. And then anything musculoskeletal. So if you, like I mentioned, tore the labrum in your hip, or you've had a back injury, your lower back has some issues, you can develop pelvic pain and painful sex also. So there's so many things that contribute, and a lot of times somebody will have interstitial cystitis, vulvodynia, and endometriosis all together. And then walking around in pain makes you depressed. And then things like depression and anxiety, they just turn up the amplifier on pain. So your brain hears that pain signal so much louder.
Sure, sure. And as you're going through so many of these things, I'm thinking about the hypermobile population that I tend to deal with. And of course, they have lots and lots of difficulties with joint dislocations and subluxations that could be in their hips, increased risk of things like labral tears. lots of
Right.
painful periods. I mean, that's a huge one that we see.
Yeah.
And of course, chronic pain. And then, like you said, the other things that come with the chronic pain and then turn that into a vicious cycle. So
Yes, yes. So I have to tell you, I didn't know much about Ehlers-Danlos syndrome until I became involved in sexual medicine, because I noticed I had quite a high number of EDS, patients with EDS, whereas in my general practice or my menopause practice, I didn't. And so I definitely see more EDS patients with painful sex because of those issues, the hypermobility, joint pain, pain in general. So, yeah.
So especially for the EDS population, this is EDS Awareness Month, or EDS and HSD. Now we call it Awareness Month. So I'm really excited to be able to do this, this month, as we're trying to really help raise awareness for these disorders. Are there certain things in particular that people can do that, of course, it's individual. This is, by the way, this is medical information, not advice. So we
Right.
everyone needs to make sure that they, consult with their own healthcare practitioners. But are there certain things that you find that you end up recommending more frequently?
Well, it depends on where their pain is and what's going on. Certainly, position changes. People with EDS might have more pain in certain positions than in other positions. I have a sheet in my office with little pictures. They're like stick figures, and all the different ways that you can adjust to find the most comfortable location for you. There are also sort of wedges or pillows that are designed for anybody with musculoskeletal pain to help prop you up, and make you comfortable during sex. So the pillows, the wedges, and then trying different positions, I think work pretty well. The other thing is to make sure that if there's anything else contributing to that pain, that you address that as well. So, you can't make the EDS go away, but EDS isn't the only thing many times that's contributing. So let's say they are menopausal and they have vaginal dryness due to menopause. Well, you'd want to treat that. You sort of want to maximize everything else that you can, change the things that you can change, because you
Right.
can't make the EDS go away.
Sure. That makes sense. And then if we can shift gears a little bit and talk about painful periods, because that's the other thing that, I really see so much of, painful men's, abdominal pain with the
Yes.
period. A lot of
Yep.
people have constipation. They have difficulty with, evacuating their bowels, which of course also can get back to the pelvic floor, the
Yes.
colon being, more distensible, that kind of thing.
Definitely.
But the periods also can be related to hormonal issues, right? That can increase pain, joint pain. You and I chatted a little bit about some of the
Right.
hormonal effects of pain. Can you talk about that a little bit also?
Yeah. So if somebody has very, very painful menstrual cramps, and I definitely see that, it's just, outside of the realm of sort of the middle of the road menstrual cramps. I usually treat people with EDS in a similar way that I would treat women without EDS to help with painful menstruation with hormones. So you could do a birth control pill, although I usually don't do that because it has been implicated in low libido because it lowers your testosterone level. But I'll use something like a vaginal ring. There are 2 rings on the market now. There's Anovera and there's NuvaRing. And basically the idea is the medicine is, you put the ring in the vagina. It's a soft, squishy ring, so nothing metal. And you leave it there for 3 weeks. Then you take it out for a week, and that's when you have a period. And it just, keeping those hormones very steady and preventing ovulation really helps with menstrual cramps. So one of the treatments, we call it dysmenorrhea when people have really severely painful periods, is using birth control or contraception, not necessarily for birth control, but you can use it for that too. Many women want both, but to really lighten flow and help with menstrual cramps. You can also use something like an IUD. This one, it varies. People's response to the IUD, the one containing progesterone, varies. Some people do great with it. Some people, their periods go away altogether, or their periods get very light. And if your period goes away altogether, that's usually pretty good, because when there's blood that's, trying to come out, the uterus is cramping. But some people don't respond as well to it because there's a foreign object in the uterus. There's something in there and your body's going, let's get rid of that. So that's another thing that you could do. Nexplanon is birth control. I don't usually use it for painful menstrual cramps because it can cause irregular bleeding. And then if you're bleeding all the time, then you're cramping all the time. So, in my professional opinion, I think either one of the rings or a birth control pill.
Sure. And somebody had made a comment about their IUD perforating their uterine wall and getting lost in their abdominal cavity, and
Right.
also Mirena being implicated in people with IIH, intracranial IIH. So yeah.
Yeah. So yes, an IUD can perforate the uterus. That is a known risk. Every medicine that you decide to use has risks and benefits.
Right.
If the benefits outweigh the risks, then maybe you would choose to use it. But IUDs they slowly migrate into the myometrium, or the muscle of the uterus, and they can end up in the abdomen. Thank goodness it's rare. It does not happen that often. But, if it happened to you, then that's 100%. So, right. But in general, it's not very common. But yes, that is a known risk of having an IUD.
Sure.
And the intracranial, I haven't heard anything about that.
Sure. So people that have Ehlers Danlos syndromes, or, and different connective tissue disorder are at increased risk of having both high intracranial pressure and low intracranial pressure. Because they can get like CSF leaks, and there's a variety of reasons why they can end up with intracranial hypertension, including, some that are vascular and different things. But I would imagine in this case with the Mirena would be probably a hormonal type thing. And like you said, I think that's such a great point, that rare complications, if they happen to you, it's 100%. So right. It's challenging because, we have to weigh the risks and benefits of everything that we recommend. And that's another super important point, that what works for one person is not going to be what works for another person. And there's no one intervention that works for everyone, right?
Right. A lot of what we do is you try this. If it doesn't work, you try that.
Sure. Could you comment a little bit about testosterone and pain?
Yeah. So this kind of has sparked my interest a little bit, and I haven't seen much data on it. Maybe you know where the data is, because it's really has more to do with Ehlers Danlos than what I do. But I have had a couple patients who I've seen with EDS, and they came in with issues like low libido, and they were menopausal. Well, let me start by saying there is not a testosterone that's FDA approved for use in women, but we use it off label, and there actually is a lot of scientific evidence that it improves libido and helps all things sexual in postmenopausal women. So I tend to use it. And if the woman has the right, risk benefit profile and sure. wants to, you certainly don't have to use testosterone. But I have noticed in my EDS patients, testosterone helps their joint pains. So I'm curious to hear what you think about that, or why that happens. But it was sort of an added benefit, and my patients were so happy about it.
Right. Yeah, I've made that same observation, and it's actually really interesting because in particular, if you have patients that are transitioning from male to female, and you are giving them, hormonal therapy for that, their pain tends to get extremely exacerbated. And wow. and the reverse happens if they're transitioning from female to male. So it's really, really interesting. And the other thing that we know is that there's lots of males, of course, that are impacted by EDS and can have quite a lot of pain, but in general, females are overrepresented. So, there's a variety of reasons why that could be the case, but we're thinking that probably a good part of that is hormonal, because we also see a huge increase in symptoms and cases, when at menarche. So when people start to get their period, that's when, so I do a timeline with people and I'll ask them, oh, well, when did you start your period? And it's not at all uncommon that they started their period and it was not long after that they started getting, more joint pain or more subluxations and dislocations and things like that. So it's
so interesting. I didn't know that about the transgender population, that getting more testosterone helped, whereas getting more estrogen was not good.
Yes. It is quite interesting.
Mm-hmm.
Yeah, definitely. So there's another question about, do you do anything for women premenopausal that have low testosterone and high estrogen?
So a couple things about that. The scientific evidence, the data that we have on using testosterone in premenopausal women for something like low sex drive doesn't really show that it works. There are some people who think that, well, you can't really test it, look at the testosterone in younger women because those tests are designed, all the labs, right? They go to a lab, those are designed for men, and women have so much less testosterone. I will use it sometimes in the perimenopausal age range, like women in their 40s. I'll use testosterone. That has been shown to help with sex drive. But the younger women, if they have a low sex drive problem, there are actually 2 medicines that are FDA approved that are not testosterone to improve libido in premenopausal women. And of course, when we talk about libido is one of the most complex things that I deal with, because it's not only your testosterone level. It has to do with your relationship. It has to do with what your family taught you about sex, how you feel about it. It can, have to do with depression and anxiety or pain, or, a partner that's not taking care of your needs. So, that the answer to low libido isn't always, oh, just give somebody testosterone. Because if they have a horrible partner, all the testosterone in the world is not going to make them want to have sex with that partner. So, in my visits, I do a complete, thorough history. I'm so fortunate. I get to spend an hour with my patients and I can ask about all the different things that can contribute. And things like chronic diseases contribute as well. If somebody's chronically ill and sick all the time, sex is the first thing to go for a woman. Whereas for a man, it has to be like starvation, famine, war before sex goes, that sexual desire. So
Right. And that is definitely something that I see, because so often when people, I'm sure you get this too, when people come for a visit and they come with their partner, and you can sense the tension. This person has been in pain for so long, and in my case, well, in your case, it's the patient is always a female, right? And in my case, the patient is more often female than male, not always, but right, in the relationship, pain itself presents a lot of challenges in the relationship, and so that definitely can be can make things a struggle. I've got another question coming in here, and I want to make sure that we address as many of these as we can so I'm just going to read it because it's a little bit long. So I'm just going to read it out loud. Okay. Following up on the last discussion, as a male with EDS and pelvic floor issues, I have been completely unable to get physician oversight for treatment. I have a pelvic floor therapist, but the urologist directing it has zero experience with EDS. My POTS and EDS doctors have gynecologists they refer to for pelvic floor issues, but none of them see men. Well, I can make a comment about that because it is really, really challenging. Again, I'm married to a urologist, and he does lots of surgery in that area, but I think when it comes to, the functioning of the pelvic floor and that kind of thing, it is really, really hard. I really empathize, with this person. I know that there are some physical therapists that specialize in pelvic floor, and I know that lots of podcasts that I've listened to and things, they'll say, well, this is not just a female issue. I know you see females, but do you have any thoughts about this person's question?
So my first thought on this is I somewhat run into this in that in my area, and I'm in St. Louis, which is a big city, I don't know anybody who specializes in EDS. And so when I've taken care of my patients, and yes, they're only female, I'll be like, well, maybe that's something you should talk to your EDS doctor about. And oh, I don't have an EDS doctor. And I've actually looked into this in my area, and there's nobody here that specializes I just wonder if, he's facing the same thing. There's just not really specialized people in it. And it's frustrating, but maybe now that we've had a pandemic and we have telehealth, maybe at some point they'll let physicians practice across state lines.
Right.
Wouldn't that be nice if you
Right.
could do a telemedicine visit with somebody who understands your condition? Yeah, because you would need a specialist, I think.
Right, right. You need someone who's highly specialized, and you definitely could have that person communicate with a pelvic floor. This person said that they have seen a pelvic floor physical therapist because, of course, the person that you're doing the consult with is not able to do a physical exam on you.
Right.
But that pelvic floor physical therapist can report their exam, and you can also see this person can see their notes. So I know that is definitely one thing that I'm really hopeful is going to come out of this pandemic. I've had
Right.
patients, I'm sure you have had,
Mhm.
fly from all over, to come see me because, and I live in a, small town. I live in Wausau, Wisconsin. So it's kind of crazy that people come here. But like you said, even in big cities, I mean, there are other people that specialize in EDS, but there's not very many of us. So yeah. Okay. So, and the person who sent that question, also feel free to reach out to me because I was at a conference with my husband once. This was many years ago, and I'll see if I can, between the two of us, my husband and I, if we can dig up the name of, there was a talk on the male pelvic floor.
Oh.
Yeah. So I'll see if I can dig up that person's name. So I'll see if I can get back to that person about that. Okay. We're getting lots more questions here. So we better address some of those. Okay. This other person wanted to know if you could talk a little bit more about hypermobility and menopause.
Me or you?
You.
Okay. Well, knowing what I know now about hormones, I'll tell you that when you lose those hormones, you also lose testosterone. So your testosterone actually starts going down in your late 20s for women, but it's really, really low when you're postmenopausal. And even if you don't have a hypermobility issue, menopausal women get joint pains when their hormones go away. That's one of the many symptoms of menopause, like their joints ache. And so if you have EDS, it's like, adding insult to injury. Now you lost the estrogen, your joints ache, your testosterone's really low. So I have definitely never seen anything in the literature about treating women with testosterone for this in particular. I do have one patient where it's completely off-label use of, there isn't a label because it's not FDA approved for women, but testosterone helps her joint pains a lot. And actually she's on estrogen too, and that helps all of her menopausal symptoms. So yeah, it's a tough one because it's just, and menopause is a very difficult time. It's common for women to be depressed or anxious around menopause. Then you throw into that chronic pain. Then you throw into it that your chronic pain got worse. It's just, so you really want to break that cycle.
Sure. And what you mentioned off-label use at the beginning of all of my talks, I have to say, by the way, all of this is off-label because for EDS, there really isn't anything that's on label. So
right,
everything that I use is off-label. So, okay. So that was that question. And then I think we already addressed that other one about why men with EDS tend to have less pain than women because of testosterone. I think the testosterone plays a really huge role because it also plays a huge role in muscle mass. And muscle mass is protective for the joints and for the other tissues. Yeah. So for the ligaments and the tendons and things. So I think it's a combination of, females having the cycling hormones and males not having that. And also the testosterone being more protective for pain. And like you said, it's not like we have a bunch of studies that show that, but we have some pretty good, clinical evidence. I mean, this is not just you and me talking about this, that I've heard this talked about at conferences and things that it would be great to be able to study this a little bit.
I agree.
Yeah, a little bit more. So it's such a needed area. So, okay. And then somebody else asked about pelvic floor therapy. Does that lead to marked improvement in penetrative sex for women? And can these issues be overcome?
Yes. So it really depends on what is causing the inability to have penetration. But many times women will have that pelvic floor muscle spasm just as a response to painful sex from whatever other cause. And I find that my patients sometimes are like, oh, that sounds weird. There's a physical therapist for the vagina and they don't want to go.
Right.
So I did create, I have a YouTube channel where I've interviewed a couple pelvic floor physical therapists who just talk about what they do, how they do it. So a woman has an idea of what to expect when she goes. But I can tell you, pelvic floor physical therapy is the greatest thing since sliced bread. When it comes to painful sex or inability to have penetration, it works wonders. It does so much good. They really teach you how to relax the muscles. Some of them do trigger point injections. If there's areas that are very painful, they can do that. And if that doesn't work, there are other things you can do to relax the pelvic floor. Sometimes we use intravaginal Valium to relax the pelvic floor musculature. And we also do pelvic floor Botox, which is another off-label use, but that just, Botox relaxes all the muscles, but it also has anti-pain properties. I learned that only recently and I was like, oh, really? So yeah, I didn't know that, but I guess it makes sense because it is used for migraines. But so there are so many things you can do if you have difficulty allowing penetration.
Sure.
But I would definitely start with PT. That is the way to go.
And I've had wonderful success with that with my patients also. And I think there's no time like the present. I mean, obviously right now, well, things are in Wisconsin anyway, they're starting to open back up to some degree, some places more open than others. But I think if people are able to get that, that would be hugely beneficial because the more that you, could you talk a little bit about like the limbic system, and if you're having painful sex and then you don't make any changes to that, I feel like that could just exacerbate the problem because now you're kind of anticipating.
Oh,
and
yeah.
Tighten up the pelvic floor even more. Like, do you?
Yes. So definitely that happens and you have to break that cycle. So if you think it's going to hurt, your natural reaction is to go like this and tense up. And you really want to be able to break that cycle. Also because of the concept of neuroplasticity, how the neurons change. Like if you have constantly having pain, then those neurons are really going to be focused on the pain that you're having and just keep firing, even if you take the source of the pain away. But definitely that, like, you know, that anxiousness about penetration can just cause your muscles to spasm. So what we do with that, and I think that's really, really important, what I recommend is you do the physical therapy, but then also I will use vaginal dilators, not as dilators, but as desensitizers. So a woman, dilators kind of look like candles and they go up in size. So they're, you know, this big, they get bigger and a wider diameter. And a woman can start with a really small one, which she puts in the vagina herself. And the way that I recommend that people do it is just let it sit there, just sit in bed, look at your phone, read a book, whatever, just let it sit there because it retrains your brain that you can have, sorry for the dogs barking. We have 4 and they're really noisy. Yeah, and if we throw them outside, they'll just bark more. So when you use a dilator, not for dilation per se, but you retrain your brain that you can have something in the vagina and not have pain. And so once you're comfortable with the smaller size, you go up to a bigger size until you can be the size of your partner without any pain. And your brain's like, oh, okay, that's not so bad. The other thing that I recommend is that when you do decide to try to have penetrative sex, because you could be great with the dilator because you're comfortable, it's you controlling it.
Right.
But when you go to actually try and have sex with a person, I always recommend that women guide their partner's penis in, that they're in control. Either they can be on top or on the bottom, but just they're the ones who are sort of running the show, because otherwise the inclination is to tense up and then you've just taken a couple steps backwards.
Sure. That makes sense. The control part too. Yeah, makes very good sense. So the next question has to do with how do we deal with the anxiety and worry of pain and subluxations happening during sex? So for people who don't know what a subluxation is, a dislocation is when the bones come out of proper alignment but no longer are in contact with each other. So if you dislocate your shoulder, the head of the humerus is like, kind of hanging forward. If a subluxation is the bones are not in proper alignment, but they're not completely out of contact with each other. So if someone has hips, for example, that sublux, or maybe they have a labral tear or something like that, that can have a big impact on their ability, to have sex. So this person is asking about how do we deal with the anxiety and worry of pain and subluxations happening during sex?
So that's a really good question. I think that a lot of dealing with anxiety is not letting yourself get on the negative thought process that just goes downhill, where you think, oh, it's going to happen. It's going to happen. It's, oh, and you have those like negative thoughts where you just sort of, spin around the drain. It's much easier said than done, right? It's much easier said than done to think positive. We're going to be okay. We can handle this. We can fix it. So there's that, to not, so kind of to retrain your brain. I like to say that, I guess, to try and not go down that spiral. But also for some people who have anxiety in general, we do use antidepressants for anxiety. And they just kind of take the edge off, so you don't get into that downward spiral. Of course, all medicines have risks, side effects, benefits, so that would be something to discuss with your physician if you wanted to go that route. There are other things I use for anxiety in general, things like the app Calm or Headspace. You can play that in the background. You can have your earpods in, whatever it takes, right? Like just to kind of keep you calm. And then the last thing that I think we don't put enough emphasis on, but I think really helps with anxiety, is breathing. So like yoga breathing. So they do, in yoga, you take like big, slow, deep breaths where it's so deep, it pushes your belly out. And then when you let it out, it's like your belly comes back in. And so I recommend that my patients take a big, deep breath, hold it there for a second or two, like breathe into a count of 4, hold it for a second or two, and then relax. And just doing that affects your nervous system and calms anxiety. So every time I have my blood pressure checked, like if I'm running to my doctor's office, I'm like, so I'm sure to not have elevated blood pressure. So yeah, those are just some things you can do to alleviate that anxiety. Sure. And it's good to have an understanding partner too.
Right. And when it comes to the issue about subluxing joints, because it could be related to the hip, it could be related to the knee. Once you start to get down to ankles or upper extremities, those are probably less relevant. But I would say for that, probably, as much as you would want to treat that in the general sense of strengthening the muscles surrounding that area, or at least neural retraining of those muscles to try to get the joint as stable as possible. Because when you're doing an activity like sex, now you're asking those muscles to function in a way that is putting extra load and extra challenging. So do you think that if someone is having, an issue with that, should they kind of take a few steps back and maybe even wait until their body is more able to handle it, so that they don't develop more of that, bad neuroplasticity that.
So I think that's a really good point. And, it's not something I would have thought of, since I don't specialize in EDS, but to really, it kind of goes back to maximizing the things that you can change. So strengthening the muscles to keep, to sort of be in the best shape for sex per se, to lower that anxiety, to hopefully lower the pain, lower it, because if you think you're going to have pain, you can, you can create it in your own mind. So yeah, I think that's a really good idea.
Okay. And I'm glad somebody asked this question, because I'm going to ask for everyone's assistance on this. Why can't we do telemedicine with a provider in another state? Please, please, please. I'm not even sure, maybe Dr. Lynn, you can suggest who they can write to, but I would love to be able to see people in a different state. But the way it stands right now, you can see people in your state that you're licensed in and that you have malpractice insurance coverage in. Mm-hmm. So if I want to see people from another state, I have to have a license also in that state and malpractice coverage in that state. There's no federal license for telemedicine that a person can get. So you have to get each individual state. Mm-hmm. And that's really, really cumbersome. I mean, it's a huge barrier.
Right.
Right. And when the coronavirus first happened, I know there was a change in the telemedicine laws at one point. I think it was we were thinking that maybe there was going to be some really significant change with the interstate thing, but now my understanding is that are you doing anything differently, I guess, than when you were before this happened in terms of like in different states? Okay.
So I actually, so I don't treat people with COVID, but I definitely see people from other states will drive to Missouri or fly to Missouri. So, but if they're in their home state, I can't see them. Right. And so when I heard about the changes in telemedicine due to COVID, I asked my attorney, I'm like, well, what does that mean for me? And I guess the way the laws were written, it's if you're doing COVID type things, then you can practice in another state. But I think it is weird because we have a driver's license and you can drive in another state, and I don't know. But one thing I was going to say is there is a consortium of states. I don't know if Wisconsin is one of them. I think there's like 13 or 14 states where if you have a license in one of those states, you can practice in the other states. You just pay the fee for the license. But Missouri is not one of those, and I'm in St. Louis. And across the river is Illinois. And Illinois is one of them. I'm like, if I had an office in Illinois, I could get an Illinois license and take part. But no, you have to live in one of those states. So they set up all these regulatory barriers.
Right.
And I really, especially if you think about all the closings of smaller hospitals in more rural areas, for someone to have to take a day off work and drive to the big city and see their physician, telemedicine would just be so nice.
Yes,
everyone involved.
It would be great for everyone involved, because right now we're asking the sickest patients to travel the longest distance, and that's exactly what I have been doing. Is people come from whatever state, it doesn't matter, come to see me in the state of Wisconsin where I'm licensed and have malpractice coverage and all of that. But then once they go home, I can follow up with them via telemedicine for a certain period of time, and eventually they need to come back here again. But it is really frustrating. Yes, we are one of the compact states. That's the regulatory body. But my understanding from some of my colleagues that have gone through that process is that still getting each license, it's easier, and it's maybe a little bit cheaper, but it's still tons of paperwork, and then you still have to purchase the insurance, and so yeah. So it's well, that's expensive then if you have to buy malpractice insurance in several states. Yeah, it is. And I don't know about you, but I have people coming from a wide variety of states. So, I guess you can pick a couple and get insurance there. But anyway, I'm glad someone asked that question, because the more that we get people advocating for some kind of licensure that would allow people that are highly specialized, like you and like me, to be able to provide some level of service, to these people that are in different states, because it's so desperately needed. Okay. So let's see. Yeah. Travel is tough when you're tired and in pain. No doubt about it. Yeah. Okay. Then someone else wanted to know, and we're going to just be able to take probably just a couple more questions here before we wrap up. Somebody wanted to know, what do you suggest for endometriosis?
For treatment for endometriosis, it depends on how old you are and well, if you want to still have children or not. Because you could always choose to have a hysterectomy, and that's kind of a loaded question, because then you're like, do you take the ovaries out? Do you not take the ovaries out? How old are you? Do you want to have more kids? Do you not want to have more kids? Are you close to the menopause? So it's a complicated discussion. But if you don't want to have a hysterectomy, and you certainly do not have to, then typically the way that we treat endometriosis is we'll start with ovulation suppression. So most of the birth control options will do that. You can use a birth control pill, the birth control, either of the rings, a Mirena IUD or a progesterone containing IUD, Liletta 2, or Nexplanon, which is the skinny little rod that goes in your arm. Those are sort of first line treatments, those contraceptives. If that doesn't work, there's a medicine out called Orlissa or Elagolix, and it sort of puts you in a menopausal state. And so when there's not estrogen stimulating those endometriotic little implants sitting in your pelvis, then your pain is better. So you can do Elagolix or Orlissa, but you can't do it forever, because if you're 25, we don't want to put you into menopause when you're 25. You can also use Lupron, which does a very similar thing, but it's a shot. Its mechanism is slightly different, but it does the same thing, puts you into menopause. You can also have a laparoscopy where you don't have, this is surgery where you don't have all your parts removed. And the only way to diagnose endometriosis is with a laparoscopy, which is surgery. We look inside your belly with a little video camera, and we can see if you have it. But also, if you have endometriosis, the surgeon can remove it. And that does a lot of good. Sometimes it comes back and the pain comes back, and there are people who have multiple laparoscopies, but we try at all costs to avoid that. So, so basically it's contraceptives, laparoscopy, hysterectomy.
Okay.
On an Orlissa.
Okay, great. And somebody asked about Kegel balls and if they benefit pelvic floor muscles.
So you have to be really careful about this, because if you have pelvic floor muscle spasm that's causing painful sex, don't put anything in the vagina that you have to tighten the muscles to hold. So for that, no, that is totally the opposite. I think many times we're like, oh, pelvic floor PT, I better be doing my Kegels. No, don't do Kegels, because you can overdo it. And then that's like the opposite of what you're trying to do. I don't really recommend them. I know that when you have incontinence, many times you want to strengthen those muscles, but pelvic floor PT is really the way to go. So I don't personally recommend them.
And my understanding, even with incontinence, sometimes that it can be that there's too much tone on a constant basis, and that you need to learn to relax in order that you can tense, when you need to. So
right.
Again, somebody doing a thorough assessment like you do in your clinic, or like a pelvic floor physical therapist would do for that, would be probably very beneficial. Okay, so someone asked about, are there any tips or tricks that couples can use when working with a sex therapist to support the body to stay more aligned and protect delicate tissues during many different types of sex?
When working with a sex therapist, well, my first thought is just, to use pillows, wedges to kind of hold you in alignment. What was the second part of the question? Sorry.
No, that's okay. And protecting delicate tissues. People who have EDS, also things can tear.
Oh,
easily.
right. Yes.
So
So what I would do is make sure you use a lot of lubrication, and I would use a silicone-based lubricant and not a water-based, because the water-based is very drying. It's good if you use condoms, because it doesn't affect the integrity of a condom, but it draws moisture out of the cells. It's a little bit more toxic. Even though it's water-based, you would think it'd be more natural and be better, but I would recommend silicone-based. And there is a silicone-based lube that is fine if you use condoms, and that's Uber Lube. You can buy it on the internet. You can actually buy it on my website, but you can also buy it directly from them. And it's a good silicone-based lube because you just don't want the tissues to be rubbing that so that something can tear. And you can put it anywhere you need that, wherever. You can put it on your chest. You can, I mean, wherever you need it.
Sure. Okay, great. And let's see. Do you think, so this person asked about, do you think organs can fall if the uterus is missing, and asked about congested pelvic syndrome?
Okay, so those are two different things. Yes, when the uterus, if you have a hysterectomy, your bladder can prolapse into the vagina, your rectum can prolapse into the vagina, and the vagina can prolapse. And all of that can happen even without a hysterectomy. The second thing was pelvic congestion syndrome. There's a little bit of controversy about that, if it's really a thing or not. I usually don't. It's a lot of times it's an incidental finding on like a pelvic CT scan or MRI or something like that. And I don't usually do much with the pelvic congestion syndrome.
Okay. Okay. And we're going to get to the last couple questions here probably. So this person says, my pain was worse a week before my period, and after my hysterectomy, it has been severe constantly. Now, what can you do to suggest to help?
So if you don't have a uterus and you're having constant pain, then if I saw you, I would look for other things causing that pain. So do you have pelvic floor muscle spasm? Do you have nerve windup? So it's kind of like, the person who has, because you can have pain just because your nerves are just constantly firing. Like the person who has an amputation, but they still feel their foot, right? Because those nerves, like they're just going up to your brain. And people with pain, with chronic pain, can get something called central sensitization. And it has to do with that neuroplasticity where your brain sort of reorganizes itself and it continues to hear pain from the pelvis, even though you don't have a uterus, even though the organ isn't there. And you treat central sensitization. Some of the antidepressants work for that, not for depression. We're not using them for depression, but they can sort of blunt the signal that your brain hears, that you hear as pain. So I'd probably look for that too.
And I'm so glad you brought up central sensitization. So before I opened my practice, which was just 2.5 years ago. I've practiced as an anesthesiologist for over 20 years in the operating room. But then my private practice, I just opened about 2.5 years ago. And I was shocked at the prevalence of central sensitization in people with EDS. It is,
I bet.
Yeah, I would say, of course, people who come to see me are because they have pain. So, that's a subset of people with EDS, but most studies show that like 90% of people with EDS have pain. It's just a question of, to what degree. But anyway, the amount of central sensitization is really amazing. I mean, I had a 10-year-old male patient once actually that said that he had pain everywhere. And the parents said, everywhere? And he said, yes, everywhere except my eyeballs.
Oh, gosh. Yeah, that's crazy.
Yeah.
Oh.
So the nervous system definitely plays such a significant role. And I'm glad you brought up post-amputation pain, because I think it helps people to understand there's so much pain in a limb that is no longer there.
Right. How is that even possible?
How is that even possible?
Yeah.
And I think it helps to understand kind of the disconnect between the pain that you might be feeling and the quote unquote damage that you might see in the tissues. Because I think people might go to get an MRI of their knee, for example, and they find out that there's really not that much wrong with it. And that can do a lot of psychological damage if you don't understand that the pain is potentially in the nervous system itself, not coming from the knee.
Right. Absolutely. I think that's so important. So important, because people will say, well, my ultrasound was normal. Why am I having pain? You don't necessarily have to see something wrong in order to have pain. And you're not crazy. You're having pain, neuropathic pain.
Right. So yeah, and that's just it. People with EDS can have all three types of pain: nociceptive pain, neuropathic pain, and centrally mediated pain. Yeah. Okay, so someone else asked, are you guaranteed to have pain with EDS or a hypermobility disorder? Oh, and I wanted to mention about treatments for central sensitization also. So I have found very good success with low dose naltrexone also, as well as a number of other different modalities. So the big thing that I think is important, and this person's question ties into it really well, is to restore hope for people. That's the biggest thing that I'm trying to do, because and I would just had this huge smile on my face when I was watching your videos yesterday, because you said people think there's nothing that can be done and there's so much we can do. And that's exactly the message that I've been trying to get out, is that there is so much that can be done. So pain is a very common thing with EDS or hypermobility disorders, super common. But there's a huge difference between pain that's controlling your life and pain where, you might have to modify how you do certain things, but it's not running your day-to-day activities, and you no longer have your brain on fire with pain. That's my whole goal, is to make it so that your brain is not on fire. So somebody said that this person that said, I have hypermobility, but scared of it developing into pain and be degenerative. Yeah. So I've seen lots of patients who have said, I want to see you kind of more preventatively to prevent problems down the road, which is great, because then I can give them a bunch of different tools. Maybe they're having a little bit of pain, but it's not terrible. Then you don't have to undo all of that windup that's happened. So are there other things that we should have asked you about that we didn't cover? Other things that you wanted to cover that we didn't get to in the last 2 minutes that we have left?
I actually think we covered pretty much everything. We covered a lot of ground.
We did.
So I don't think so.
We did. And people asked really great questions. And I just so appreciate you taking the time to chat with me today. This is such a desperately needed area. And I don't know that I've really seen anybody talking about painful sex with hypermobility before. We talk about a lot of different things, but this is a population of people that does have chronic pain. So that impacts relationships, that impacts positioning.
I do have one thing just to say, that if you're interested, I have a YouTube channel with many videos about human sexuality, dealing with low libido, painful sex. I have, you can follow me on Facebook, which is Becky K. Lynn, MD, or Instagram, which is the same thing, Becky K. Lynn, MD. And I always post interesting articles or interesting things that I learn about. And then on my website, I write a blog. So I'll just pick interesting things to kind of write about. And my website is Evora, which is E V as in Victor, O-R-A. And then the rest is by Dr. Becky Lynn. And doctor is just D-R. So Evora by DrBeckyLynn.com. And my blog is there. You can sign up for my newsletter. I like talking about these things. I want to make sure that everybody knows that there is treatment.
Fabulous. And I will go into the thread on Facebook and add links to those places also, so that it'll make it easier for people to find.
Perfect.
So yeah, and her videos are fabulous. For anyone who has not yet watched the videos, they're really fantastic, and you can, pick and choose from the menu of what things you'd like to learn about, and they're widely varying in length. Some are super short and cover, just a very discrete topic, and others are a little bit longer. So it's a great place to go for more information. So fabulous. Well, thank you so much for joining us, and thank you everyone for being such an engaging audience and asking great questions. So
thank you.
Yes, absolutely. All right. Well, this is Dr. Linda Bluestein again, the Hypermobility MD, and I've been chatting with Dr. Becky Lynn from the Evora Center for Menopause and Sexual Health. And we will add some links onto the Facebook conversation here, and we look forward to staying in touch. Thanks so much.
All right, fantastic.
Bye-bye. Thank you again.